to have Professor S.R.Chandra, a retired professor from NIMHANS, Bengaluru, as our mentor today. A very warm welcome to you, ma'am.
Thank you.
Dr. Vijay Balaji, a second-year MD Medicine student from M.S.R.M.C. Bangalore, has volunteered to present a case on peripheral neuropathy. A very warm welcome to you, sir.
Thank you.
A very warm welcome to all the audience joining us today. With the permission of ma'am, we can start the presentation.
We'll start.
Yes, ma'am. I'll be presenting a case of a 54-year-old female, Ms. XYZ, who's a housewife by occupation, who resides at Mandya, who's a right-handed person, who came with the chief complaints of weakness of bilateral lower limb since 2.5 years, with pain in the bilateral lower limb since 2 years, and pain in the upper limb since 1 year. History of presenting illness. Patient is a known case of type 2 diabetes mellitus since 10 years. The chief complaint started with weakness of bilateral lower limb since 2 years, which was insidious in onset, gradually progressive to the current state. Initially, was able to walk about 60 to 70 yards. Initially symmetrical in onset, affecting both the limbs. It was progressive in nature to the current state, and because of which she has stopped walking. During the onset, there was no history of any falls, any buckling or pain that the patient noticed. There is no history of any loss of consciousness, giddiness during walking, any cranial nerve involvement or stiffness of limbs or any hypertrophy of muscles that was noticed. There is no history of any difficulty in squatting or getting up from sitting position or any bladder involvement. This weakness progressed over the next 5 months such that patient also complained of difficulty to get up from the squatting position since 1.5 years, for which the patient used both the hands for support to get up. Following that, the patient also noticed weakness of the bilateral upper limb since 1 year, which was insidious in onset. Initially, the patient noticed difficulty with mixing food, buttoning and unbuttoning of blouse, which was progressive in nature, such that the patient had some difficulty in moving the elbows. There is no history of difficulty in combing or raising the hand above the head or holding the neck. Following that, the patient also noticed buckling while walking, which was painless since 8 months. Almost 6 to 8 episodes, it was present almost throughout the day, following which she stopped walking. Patient, coming to the sensory symptoms, patient started noticing a pricking type of pain in the bilateral lower limb since 2 years. It was symmetrical in onset, initially over the soles and dorsal surface of the feet. It has gradually progressed to the current state up to the mid-thigh. It is present throughout the day, aggravates on standing, walking, and relieved partially on medications. It disturbs the sleep. There is no band-like sensation or shock-like sensation during movements. There is no change with cough, sneeze, or straining. The patient also noticed decreased perception of cold and hot in all the 4 limbs since 1 year. Initially, it was noticed in the bilateral lower limb and gradually progressed up till the mid-thigh since 1 year. And 1 month later, patient also noticed similar complaints in the upper limb, initially in the hands, and currently up till the elbow, she has reduced sensation throughout the hand. It is present throughout the day with no any diurnal or aggravating and relieving factors. During this, the patient also noticed there is history of swaying during washing the face on standing when she closed her eyes since 10 months. There is no history of significant weight loss. There is history of significant weight loss since 1 year, which was 10 kg weight loss in 1 year the patient has noticed. There is no history of trauma to the spine. There is no history of any bowel and bladder disturbance. No history of respiratory distress or difficulty. No history suggestive of any cranial nerve involvement. No history of band-like sensation or exposure to OP compounds or toxins. No history of joint pain or rash. No history of postprandial fullness, palpitations, or loose stools. The patient was diagnosed with tubercular cervical lymphadenitis 6 months ago and has received the full course of ATT, which was completed 1 month ago. Also known hypothyroidism on 100 microgram of levothyroxine. Patient is a known diabetic since 10 years and he has been irregularly on medications and predominantly uses OHS. No history of hypertension, bronchial asthma, seizure, COPD or similar complaints in the past. No history of similar complaints in the family members. No history of exposure of tuberculosis in the family members. He consumes a mixed diet, has the sleep is disturbed since the past 1 year. Bowel and bladder habits are regular and he denies any deleterious habits. Coming to
Okay.
the... Yes, ma'am.
Shall we discuss each symptom?
Yes, ma'am.
You said that initially she was able to walk 60 to 70 yards. No?
Yes, ma'am.
That was her usual walking speed. Huh?
Usual walking speed, ma'am. There is no reduction in speed, no pain.
So initially, that was her normal walking speed.
Yes, ma'am.
Because it varies from person to person.
Yes, ma'am.
Initially, what happened was reduced walking speed. Was that the thing?
No, ma'am.
The first symptom.
First symptom was reduction in the walking speed and the distance, ma'am. The patient
Could she run? Could she run?
She could run, ma'am. She could run.
So what do you understand by the term reduced walking speed? So reduce fixed distance walking time. That is what we call walking speed. You see, it varies from individual to individual. So how much time you are normally consume for comfortable walking? When you are having comfortable walking, there is a fixed time that we take. That is called fixed distance walking time. So fixed distance walking time in comfortable speed is different for different people. So this person must have had a particular fixed distance walking time before and that got reduced. Probably that is what this patient's symptom is. Yes. So what will happen normally, a male in the family who is walking in front slowly starts walking behind the wife, or the wife who walks in front of the children starts walking behind the children. So that is reduced walking speed. So customarily comfortable fixed distance walking time is individual and that particular time has reduced. So what all situations it can reduce? That is the question. At this point, there is only that at that point of time. So it can happen with so many things. One, it can be part of an extrapyramidal disorder, like bradykinesia. Second, it can be part of a claudication. Third, it can be due to painful limb conditions. Or it can be decreased executive function, which can be due to depression or organic disease. So these are the possibilities when somebody is telling that my mother, who used to be very active and walk my house to the shop in 5 seconds, is now slow. So you have to find out whether she was at that point of time, was she having any associated affective change? Did she have any features of depression? A senior person developed tuberculosis and all those things. So she was saying, then it will be only mental slowing. So we will want to see slow. Is it because of the mindset? That is called mental slowing. You can have weakness, that is called motor slowing. Or you can have mixed slowing. You can have a mental slowing, you can have a motor slowing, and you can have a mixed slowing. What is that mental slowing? Oh, why I will go at this time only? Why I should go fast? You go forward, I am not interested. So if that person is saying it is purely mental slowing, so lacking initiative, so you probe into the sleep pattern, appetite, any suicidal ideas, any depressive things which happen, then you know it is a mental slowing due to depression. Supposing you have got a mental slowing with no definite features of depression, but patient is not wanting to plan that I have to catch my bus to reach my office, then it is an organic mental slowing. Frontal lobe syndrome, that we call it as dysexecutive. Executive function failure, dysexecutive. So if there is an organic mental slowing, that happens in frontal lobe disease, early frontal lobe syndrome. In a diabetic patient, it can be due to Binswanger syndrome, or she is having tuberculosis. She might have silent meningitis with hydrocephalus, frontal horn dilates. So in the context of this particular patient, it can be a vascular Binswanger's, or it can be frontal horn dilatation due to hydrocephalus. In that situation, patient will be slow. She will not set her goal, but she will not have depressed feelings. She will not have sleep changes. She will not express suicidal ideas. Then you will know that it is an organic dysexecutive syndrome. Next is Mendel plus motor. Supposing you have got a frontotemporal dementia with Parkinsonism, or you have even Binswanger's disease. So they also have subcortical vascular PD will be there. So they are mentally slow. Their gait is also slow. So even if they want to move fast, they are unable to move. They have got altered gait semiology. Then you know it is a cortical plus subcortical. So first, whether it is Mendel slowing, it is not. Then depression and organic dysexecutive is tried how to differentiate. Then if it is associated with motor slowing, it is definitely organic. Only Mendel slowing, whether it is dysexecutive or depression is coming. If there is associated motor, it is definitely organic. So it can be pyramidal, it can be extrapyramidal, or can be manifestation of NPH, Binswanger's, NPH, PD dementia, all those conditions you will consider. So if that is not there in this patient. Next is the person having bradykinesia, slowness. So whether there is an associated postural abnormal without any executive function, the classical idiopathic PD or the primary Parkinson's disease, that starts as only motor slowing. It will not have Mendel slowing. So motor slowing with altered posture, slowness, and altered gait semiology, then you know that it may be reduced arm swing, slowness in every other activity. Then it is probably akinetogenic type of Parkinsonism. We have got a tremor dominant Parkinsonism, akinetogenic Parkinsonism, and a mixed Parkinsonism in the idiopathic type. So it may not be the tremor dominant. Tremor dominant will be very evident. Whereas slowness dominant, even it can present as back pain, neck pain, periarthritis. Because of the slowness, the joints become stiff. So patient will go to orthopedic. They will think it is a back pain or periarthritis shoulder, and slowly after 6 months or so, the classical Parkinsonian features will come out. So it can be due to non-tremor dominant type of Parkinsonism. That's the next thing in order. Then next you have got whether it is a claudication. In the claudication, again the fixed distance walking time reduces. What makes the patient reduce it decides whether it is a neurogenic claudication, whether it is a vascular claudication, or a pseudo claudication. So persons with diabetes are prone for vascular occlusive disease. So they can have a vascular claudication, or they can have pseudo claudication. And the neurogenic claudication is of course unrelated. So how are you going to differentiate these two? So all these things which will go through our mind, how to differentiate vascular claudication from neurogenic claudication. What is common in vascular claudication, neurogenic claudication, and pseudo claudication is fixed distance walking time is reduced, which is not due to depression, not due to executive failure, not due to extrapyramidal disorder. Then if it is due to vascular claudication, patient will have severe pain in the cough. Whereas neurogenic claudication, after walking for some distance, patient may develop numbness and weakness. Whereas pain is not that obvious. It may be some kind of paresthesia rather than the severe pain of vascular claudication. Second thing, trophic changes. Nail changes, skin changes, and hair changes are very early in vascular claudication. Whereas in neurogenic claudication, they may be pre-terminal, very late. After several years of neurogenic claudication, patient can develop trophic changes. Third, objective coldness of the limb. So patient feels my limb is cold, and you palpate the limb, you also find it cold. So in vascular claudication, both subjective and objective coldness of the limb is there. Whereas in neurogenic claudication, subjectively they may feel cold, but objective coldness will not be there. Next, when you climb up and climb down, vascular claudication is usually affected in the same way. The patient will have the pain in the calf, which halts the patient while he climbs up or climbs down. Whereas neurogenic claudication becomes worse while climbing down. Because when you are climbing down, you are bending your spine and the nerve roots get stretched. So neurogenic claudication, climbing down becomes more difficult. Then you will find after exertion, appearance of new neurological signs like abs and ankle jerk, which was not there at beginning. After exerting for some time, you examine the patient, you find new signs like loss of ankle jerk, which will not be there in vascular claudication. Then, of course, you know the vascular claudication, you will have pulse deficit, which is not there in neurogenic claudication. So that is the difference between neurogenic claudication, and neurogenic claudication can also be precipitated by standing. The symptoms of neurogenic claudication can also come by standing, whereas vascular claudication never comes on standing. It comes only on walking. Next is, what is pseudo claudication? After exerting for some time, patient is unable to move forward. Patient has to rest for some time and then picks up the walking. So you know it is probably a claudication. And we examine and investigate for vascular claudication and neurogenic claudication, and nothing is there. Neither the vascular compromise is there nor the neural compromise is there. So that is called pseudo claudication. This happens in some conditions. One is situations associated with microvascular ischemia. You know that in angina also you have got a large vessel angina and a small vessel angina. Similarly, it is a small vessel vascular claudication. That happens in diabetes due to microvascular abnormalities. It happens in polymyositis. Because polymyositis, there is a vascular component. It's a perivascular inflammation. So it happens in polymyositis. Then it can happen in conditions like multiple sclerosis. In multiple sclerosis, it is not vascular. In multiple sclerosis, what happens is after exertion, there is aberrant activation of voltage-gated calcium channels. The same thing happens with exposure to heat. That is why you get phenomena called Uthap sign. You take a hot water bath, you become blind. Or you stand in the sun, you become ataxic. So similarly, after exertion, patient develops new signs and symptoms and unable to walk. So pseudoclaudication is either microvascular compromise in diabetes or polymyositis, or due to aberrant activation of calcium channels, which happens in conditions like demyelinating disorders. So that is, so yeah, all those extrapyramidal and all not possible. Claudication we cannot rule out. Now we have to find out with the symptoms available whether it is vascular, pseudo or neurogenic. Then you have got painful limbs or not. That you have to find out whether there is a pain. So it can be other causes like a joint involvement. So when the patient is walking some distance, is the patient forced to stop due to pain in the joints? No, that also you have to ask. So that is not there. So considering the symptom which is not associated with depressed feeling or subcortical stiffness or altered posture or semiology, and only the walking distance became reduced, I think it is a claudication pain. Whether it is a vascular claudication or neurogenic claudication or pseudoclaudication, we need examination and other additional features. So we will keep it as a claudication, probably pseudoclaudication of diabetes. Maybe she developed microvascular ischemia symptoms as the first manifestation because she is a chronic diabetic with a very erratic drug regime, you are told. So she might have had a lot of metabolic decompensation on and off. That would have led to vascular complication first and maybe causing us a pseudoclaudication of diabetes. Possibly a pseudoclaudication of diabetes, the first symptom, I think so, excluding all other things. So when somebody says reduce fixed distance walking time, you should start from mental slowing, motor slowing, mixed slowing, claudication pain, vascular changes, and painful limbs. All this you have to analyze and then we will choose which is fitting into our patient. Probably it is pseudoclaudication, I am thinking, because you did not mention, even though you said that cold was not appreciated, patient did not have subjective or objective coldness. It is only not appreciating coldness. So that is a different thing. So probably it is a pseudoclaudication. Next, you told she has difficulty in getting up. No? Was it the next symptom?
Yes, ma'am.
Next symptom is getting up.
Yes, ma'am.
So weakness of both lower limbs, 2 years, gradually progressive, 70 or symmetrical, affecting both limbs, progressive nature to the present state due to which she stopped walking. But except the slowness, what is the next symptom? She had weakness process such a way that patient come difficult to get up from the squatting position and required use of both hands for support to get up. So this we have analyzed many times. So would you like to analyze, ma? You tell what is that symptom could be. She needed both hands to get up.
So it indicates a proximal muscle weakness, ma'am.
Lower limbs with retained paraspinal muscles.
Paraspinal muscle normal.
Yes, so paraspinal muscles were not affected. That is why she could get up by using her hands. So it's a proximal muscle weakness. You have to ask whether she had a hip up. If she had the hip up sign, it means gluteus maximus. If she had the hip dip sign, it is gluteus medius and minimus. If she had to lift her thigh with the hand, it is iliopsoas. So first impression, it is proximal muscle weakness with retained paraspinal muscles. Only if the paraspinal muscles are normal, patient can get up by keeping her hands on the side of the floor or the chair or whatever it is. So she could do that. That means paraspinal muscles are not affected. It's the proximal muscle. So based on the semiology, we have to ask more. Was she having something like a hip up? Then it is gluteus maximus. So she will bend the trunk and get up. Slightly stoop forward and get up. They will stoop like this and get up. When it is severe degree, they almost bend down. Or if she is hip dip, when she is trying to get up, the hip on that side is dipping. That is gluteus medius and minimus. That is point that because there is something called phenomena of selectivity in muscle disease. So that is why this is important. Gluteus medius and minimus is commonly involved in dystrophic muscle disease, whereas gluteus maximus is commonly involved in metabolic muscle disease, whereas iliopsoas usually involved in infiltrating pelvic radiculoplexopathies, ovarian tumor, infiltrating into the brachial plexus, or hemophilia patient bleeding into the brachial plexus, or plexopathy due to diabetes. Those situations, it is the iliopsoas that get affected. This is called as pattern recognition. So each pattern will help us to think of the etiology also. Not in this case, but generally if the person is young person and not having any of these complications, it is becoming important. So it's a proximal muscle that was affected first. At that time, she did not have any sensory symptoms, I suppose. No? So proximal muscles. So first pseudoclaudication probably, then proximal muscles. Next symptom, upper limbs. So it progressed to the upper limbs. So it started proximally, and then instead of going distally, it went to the upper limb. So in the upper limb, it is distal.
Yes, ma'am.
Non-length dependent pattern. So it is in the lower limb, it did not go from the proximal to the distal. No?
No, ma'am.
It was in the proximal and then it went up to the upper limb.
Upper limb. Yes.
So in the upper limb, it is mixing of the food. Which muscle is involved in mixing the food, ma'am?
Lumbricals and interossei, the small muscles of the hand.
Proximal lower limb, distal upper limb. So it is mixing of the food is lumbrical. No? So if you are having buttoning and unbuttoning, then it involves opponents, lumbricals, as well as some help from the interossei. So mainly mixing food, mainly it is the lumbricals. If you have to button, you use your opponents as well as the lumbricals. So that was also defective. So gripping the pen was difficult. No, gripping the pen was difficult. So that involves opponents. So lumbricals and the opponents were involved. So it is a small muscles of the upper limb. So that also it is motor only, no sensory, no? Upper limb also motor.
Initially motor, then developed sensory symptoms.
So to start with, it is lower limb proximal, upper limb motor. The next is the painless buckling.
Yes,
Again, it is motor only, painless buckling.
yes,
So painful buckling, what all conditions you get?
usually there should be ligament injury or meniscal injuries that can cause.
So it is cruciate ligament or meniscus injury, you get a painful buckling. Or other kind of destructive joint disease, including osteoarthritis and monoarticular or polyarticular arthritis, you get a painful buckling. In joint disease, sometimes you get painless buckling in sensory denervation like cluttons and pseudo-tabetic joints due to tabes. The distal joints will be cluttons and proximal joints will be, what is the name of the, you get a large joint pseudoarthrosis. So the joint gets damaged due to loss of trophic changes. So they develop painless joints in neurological disorder also. Painless joints can happen in neurological disorders due to sensory denervation, usually seen in tabes or pseudo-tabes or diabetes. So it's a painless buckling. So is it motor or is it due to some kind of joint, but no sensory symptom at all was there. So you're not going to think of a pseudo-tabes of diabetes. Pseudo-tabes of diabetes, sensory symptom will start. It is not there. So you're not going to consider that. So buckling is quadriceps.
Yes.
So quadriceps weakness will produce buckling or nerve supply to the quadriceps, femoral neuropathy. You have got diabetic femoral neuropathy, or you can have L3 radiculopathy, or it can be myelopathy. So painless buckling can be due to quadriceps weakness, or it can be due to femoral neuropathy. Usually L3 radiculopathy is painful, or it can be due to stiff buckling due to pyramidal weakness. So is it a stiff buckling or a flail buckling? Painless buckling, was it stiff or flail?
No stiffness, ma'am. It was flail.
No stiffness. So it is LMN.
LMN.
So no pain at all. So we'll consider L3 radiculopathy as the least possibility. Femoral neuropathy is just behind that. And the most possible is again quadriceps muscle at the level of the muscle, probably at the level of the muscle. Then next she developed. So proximal involvement seems to be in the thigh. It seems to be predominantly motor. Motor means it may be muscle, motor neuropathies, radiculopathies, and it can be anterior console. So far in the lower limbs, it is proximal motor. Proximal motor can be at the level of the muscles. It can be at the level of motor nerves. It can be at the level of radicals. Like conditions like CADP can complicate diabetes also. They involve the proximal. Why the radicals involve the proximal first? Proprioception, you will get it on examination. Otherwise, patient will tell proximal weak. Because demyelinating radiculopathies respect the pattern of myelin. Wherever the myelin is more, they will be affected. The short nerves have more myelin. Short roots have more myelin. Radiculoneuropathies, CIDPs are radiculoneuropathies. Short roots have more myelin. So wherever myelin is more, that becomes affected first. So it will closely mimic muscle involvement because of its proximal involvement, but that is due to respecting the myelin. So it will be proximal. So whether it is at the level of muscle, anterior horn cells, motor roots, these are the possibilities we will keep in our mind. So would you like to tell me muscle, anterior horn cell and motor roots? So if you say it is motor roots, we do not expect all the roots to be involved. If you say motor roots, if all the proximal, hip flexion is L1, hip extension is S1, hip abduction is L5. So if it is only proximal roots, no root, motor roots, if you say proximal, that is patchy. It looks like patchy. So we cannot say no. As I said, demyelination can prefer like that. So it should be involving L1, S1 and L5. If it is a radiculopathy, possibility is there. We will examine, and if you find associated proprioceptive involvement, we will favor for a nerve involvement. Next is muscle. In this patient, metabolic myopathies, neuromyopathy, Osteomalacia, patient is sitting inside with tuberculosis, she can develop hypocalcemia. All these can cause muscle weakness in this patient. In that case, metabolic muscle diseases are non-selective. So when we examine, unlike the dystrophic muscle disease, those metabolic muscle disease we call them myopathies, whereas genetic muscle disease we call them muscular dystrophies. So progressive genetically determined muscle diseases are dystrophies. So progressive muscle disease which is not genetically determined, we call it as myopathy. So how to know whether it's a dystrophy or a myopathy? Not in this case. For general discussion, dystrophies have selectivity. Based on the type of muscle disease, there is selective muscle involvement. All the muscles do not get involved. Whereas in metabolic muscle disease, all the proximal muscles get involved because it is the bulk of the muscle that determines. So there is non-selectively. When you are examining, you are finding adductors are weak, abductors are weak, flexors are weak, extensors are weak, internal rotators, external rotators, all are weak. So it's a non-selective weakness. So if it's non-selective weakness, it is a metabolic muscle disease. Whereas dystrophic muscle disease will show selectivity. Then second point, age group. This is not the age you get a dystrophic muscle disease. Younger. Third, associated pseudo-hypertrophy. Atrophy, family. So pseudo-hypertrophy, segmental hypertrophy, segmental atrophy, family history, and younger age. That will favor a dystrophic muscle disease, whereas lack of selectivity, no family history, no pseudo-hypertrophy, only wasting, no pseudo-hypertrophy. That is a feature of metabolic. Then should we think of anterior horn cell disease? So anterior horn cell disease which manifests as pure element is not seen in older people. They are SMA, spinal muscular atrophies. They are the anterior horn cell disease which are purely element. Whereas other all anterior horn cell diseases are LMN plus EMN and rarely LMN alone. They form a separate group. We know that progressive muscular atrophy. That usually manifests in the 4th decade. And purely progressive wasting of the lower legs. And you have got wasted leg syndrome, wasted hand syndrome. They are all unilateral, one limb, and very young people. That all affects the 3rd to 4th decade, not this age group. Then motor neuron disease usually involves the distal upper limb, distal lower limb with spasticity, bulbar involvement. Whereas SMAs are proximal, distal SMAs are exceptions. And they all manifest by the, at birth, you have got the English SMA classification, we call them, Wielander, Kugelberg, Wernicke-Hoffman, then in the early childhood, then young adult, then older adult. So by 4th decade, it all becomes symptomatic, fully symptomatic, depending on the type. Wielander, Kugelberg, Wernicke-Hoffman is at birth. And by 4th decade, they become complete. So proximal muscle weakness is a feature of anterior horn cell in SMA. So it is very unlikely. But what anterior horn cell can manifest in this age group is post-polio anterior horn cell disease. Supposing this person has got a poliomyelitis in one leg. And she, in the left leg, let us imagine, she was having an old polio in the left leg that which she was managing. Now she develops suddenly a purely promotor proximal vessel weakness in the previously unaffected limb with the fasciculation, fibrillation. Then it can be anterior horn cell. So that is what manifests in this age group. Other anterior horn cell disease, as you clearly know, it's ALS, or you have got pseudobulbar palsy, bulbar palsy. They are all typically happening in older age group. They have both MN and LMN combination, and this is not the pattern, and they are not proximal ones. So that MND, you see, doesn't have anything to suggest a old polio. So anterior horn cell is less likely. Muscular dystrophy is less likely. If it is symmetrically involving all the muscles. So for the proximal weakness, we have only 2 DDs, whether it is a radiculopathy or is it a myopathy. Metabolic myopathy. We will examine and decide whether it is at the level of the muscle or at the level of the roots. Next symptom is distal upper limb.
Yes, ma'am.
So distal upper limb can be, it is again motor, no?
Yes, ma'am.
So it can be either neuropathy or anterior horn cell. Anterior horn cell can affect the distal part in the older person. So when you examine, if you find fasciculatory tremors, in the limb you are finding tremors, or you find fasciculations, and you don't find any, even you are objectively not able to elicit any proprioceptive dysfunction, then you will see whether it is an anterior horn cell. Then another, you can remember the pattern recognition. Proximal lower limb and distal upper limb. Can you tell some conditions? Proximal lower limbs and distal upper limb.
Inclusion body myositis.
Yes, that's a typical classical. So classical pattern recognition is proximal lower limb and distal upper limb is inclusion body myositis. So that we will not consider in this case because so many other things are following. So that is the pattern you find. Each one has got a pattern. You have to see the pattern recognition. Old age. What is old age, ma? No, we are not thinking of inclusion body myositis in this case. I am just discussing the differential diagnosis. I will not diagnose. It's a very rare disease. And I have myself seen 2 or 3 cases only proved, and it will have a definite pattern that is there. Not, I am just telling you the pattern. This person is having proximal lower limb and distal upper limb. So whether it is an inclusion body myositis, if it is at the level of the muscle, or it can be radiculoneuropathies. Radiculopathy in the lower limb and neuropathy non-length dependent in the upper limb. So what all situations you can get? Radiculopathy in the lower limbs and neuropathy in the upper limb, non-length dependent. Very typically it is seen in Sjogren's disease. Sjogren's disease. So each condition, this pattern I am trying to discuss, not this case. I am not diagnosing. I am only analyzing the symptom. So you have a proximal lower limb and a distal upper limb. So you have to think whether it is a radiculoneuropathy, non-length dependent. Then you have to think of conditions which affect in this pattern non-length dependent person. One is Sjogren's. Other conditions, organophosphorus compound poisoning, chronic organophosphorus compound poisoning. You can get sometimes in amyloid. You can get it in Tangiers. So non-length dependent, this kind of short axons can be involved in chronic organophosphorus, amyloid, Tangiers. All those age group is different. In this age group, it will be paraneoplastic amyloid or amyloid complicating tuberculosis. That kind of thing only you have to consider. But these are non-length dependent. Sjogren's and organophosphorus compound and amyloid and Tangiers. So that is the radiculoneuropathy, second. Then you have got a condition called neuromyopathies. Neuromyopathies. That is proximal myopathy and distal neuropathy. You get it in, so you have proximal myopathy in the lower limb, which is symptomatic because patient is ambulant and trying to buckle. She is symptomatic with the proximal muscle. It's a weight-bearing body part. Whereas in the upper limb, the most used body part is the distal part. So whether she has a mild distal sensory neuropathy, we don't know. We will have to elicit because the weight-bearing limb will buckle first and she recognizes the weakness in the lower limb. And proximal limb, we use distal part more than the proximal part. So she is recognizing that. And the symptomatic side is neuromyopathy. That can happen. 1, it can happen in diabetes. 2, it can happen in vasculitis. 3, it can happen in autoimmune disorders. And 4, it can happen in HIV. No? So these are conditions where you get autoimmune toxic also, some toxins. So neuroproximal myopathy and distal neuropathy is seen with diabetes, vasculitis, autoimmune neuromyopathies, HIV associated neuromyopathies, and some toxic metabolic conditions which can produce affect nerve and muscles. So whether these are the things we'll have to consider at this point. If she is coming to us with a proximal lower limb and a distal upper limb, these are the patterns which you have to recognize, and M&D goes out. Radiculopathies and neuromyopathies become our, we are now becoming wiser. Whether it is a radiculopathy or neuromyopathy is the differential diagnosis at this point of time. Later she developed pricking sensation, pricking pain. No? So what is that pricking pain? A prick is carried through which fiber? Prick. Pain fiber.
Pain fibers.
Prick is carried by the small fiber. It is the pain fiber. So she is developing an irritative symptom. Patient is developing an irritative symptom involving the small fiber. The upper limb also, you said it is pricking, no? So is it in a radicular pattern or in a peripheral nerve pattern? That is the next question. If it is distal, symmetrical, circumferential, then it is a peripheral nerve pattern. It is patchy, asymmetrical, it is radicular. So because proximal, we are thinking whether you have to consider a radical. So distal, is it again a radical or a nerve? So if it is asymmetrical, it may be radical. And if it is symmetrical and distal, it can be nerve. So I think in this patient, it is distal and symmetrical. So it is likely to be a nerve pattern, not a root pattern. So small fiber involvement. So many things are now coming together. So you see, she started with something like a pseudo claudication. That suggests a microvascular ischemia. I am audible, no?
Yes, ma'am.
So next, now she developed a proximal muscle weakness. That is motor. Whether it is root or muscle, we are keeping it as pending. Then she is getting a small fiber in the lower limb. So among the neuropathies, as I have told, demyelinating neuropathies, if it is a proximal radiculopathy in this patient, that's a demyelination. I told you, proximal roots are myelinated roots. So maximum myelinated roots get involved in demyelinating disorder. In that situation, if it is a radiculoneuropathy, in this patient, the distal should be proprioceptive, tingling sensation. We expect the patient to tell tingling sensation. Instead, she developed pricking sensation. So that doesn't correlate with the motor root. Demyelinating disorders involve the most myelinated fiber. What are the most myelinated fibers in the nerve? It is the motor fiber and the proprioceptive fiber. Intermediary myelination is pain and temperature fiber. Unmyelinated is the C fiber. So you have got unmyelinated C fiber, intermediary myelinated pain and temperature fiber, and most myelinated fiber is the motor fiber and the proprioceptive fiber. So if my patient is developing a radiculoneuropathy and the proximal involvement is due to the demyelinating radiculopathy and it is a myelin-based disorder, then I will expect her proprioception to go first. Instead, in this patient, it is the pain and temperature, which went small fiber. So that distal part at least is not demyelination. Proximal part, we will keep it as pending, whether it is a demyelinating radiculopathy or a metabolic myopathy. Both possibilities are there. Distal is definitely a small fiber neuropathy because it is pain and temperature fiber that has got involved. Initially, it was an irritating symptom and next was the destructive symptom. So what is the term that we use for a irritating symptom? Paresthesia.
Paresthesia.
So how do you define paresthesia? Sensory perception in the absence of sensory stimuli. So paresthesia is sensory perception in the absence of sensory stimuli. So she had sensory perception in the absence of sensory stimuli, and the character of the paresthesia looks like a small fiber. So initially she started with the irritative symptom of the small fiber and went on for the destructive symptom of the small fiber. That is, she lost appreciation of cold and she lost appreciation of warmth. That is what you told. So the next, after the proximal muscle, it picked up the small fiber. So what is it that affects the small fiber?
Nerves.
Vasculitic process. So demyelinating disorders involve the proprioceptive fiber and the motor fiber. Whereas vasculitic disorders or vascular compromise, whichever is producing vascular dysfunction, they involve the pain and temperature fibers and they spare the autonomic, they involve also the autonomic fibers. Whereas toxins, supposing some diabetics, they take Ayurvedic medicines or take some unconventional, siddha, heavy metals, all those things, they involve the small fiber but spare the autonomy. So the pattern is demyelinating disorders involve the motor fibers and the proprioceptive fibers, whereas vasculitic disorders involve the small fibers. That is why vasculitic neuropathy patients develop punched out ulcers, small punched out painful ulcers. So small vasculitic involves the small fibers. And diabetes as such involves the small fiber. Vasculitis is not small fiber plus autonomy. So there will be dryness of the skin, loss of sweating, loss of hair, nail changes. So small fibers, pain and temperature plus autonomy gets involved in vasculitic process. Whereas toxins differ in the sense that they spare the autonomy. Except some exceptions are there where the toxins involve the autonomic, like thallium poisoning. Thallium is mainly a motor neuropathy, but it can involve the autonomy. Alopecia, motor neuropathy with autonomic involvement. So autonomic involvement is an exception in toxins. And small fiber, all anti-cancer drugs and all, they produce severe small fiber neuropathy. So toxins involve small fiber neuropathy, sparing the autonomic with some exceptions. Whereas vasculitis involves the small fiber neuropathy, including the autonomic. Demyelinating involves the large sensory fibers and the motor fibers. So that is a pattern. So now we are getting a patient who is having a proximal motor, whether it is root or whether it is muscle, we are keeping it as pending. And distal, we are getting a small fiber neuropathy, both involving the upper limb and the lower limb. No? And she had something like a pseudo-claudication. What is the next symptom? Later she develops wash basin sign. That is the last thing. Yes. The last thing that happened is the completion phenomenon. So at the end, everything will go. So the last, whereas if it is demyelination, the first thing to go should be the proprioception, and the pain and temperature and autonomic should go later. Whereas now this patient is developing wash basin sign, that indicates the disease process is quite advanced. But the semiology of involvement is proximal motor, then the distal small fibers, and then it goes on to the large distal sensory fibers. What other, did she have any positive features of proprioception like tingling sensation or?
Once she developed this wash basin, just before that she started developing positive symptoms.
So would you like to tell me all the features of a large fiber, large sensory fiber involvement and large sensory column? Because you can also get column involvement. That is why we call it a pseudotabes in diabetes. Diabetics can get pseudotabes, no? Posterior column also can get degenerate. So would you like to differentiate posterior column from proprioceptive peripheral nerve?
Peripheral nerve, usually it will be, they'll have positive symptoms like tingling, numbness. That will be there more common in peripheral nerve.
Whereas in posterior column, they develop a tract pain.
Full.
So whereas in large fibers in peripheral nerve, they develop a nerve type of symptom. That is a tingling, paresthesia, distal symmetrical. Whereas if it is a column, they will get a girdle sensation, Lermite sign, lightning pains, glove and stocking hyposthesia, and bizarre asymmetric sensory symptoms in the limbs. It may be up to the ankle in one leg and up to the hip in one leg. You may think it is psychogenic. So Lermite sign, girdle sensation, lightning pains, glove and stocking hyposthesia, bizarre sensory patterns which cannot be described by whatever pattern you know, and a deep boring paresthesia, because proprioceptive fibers receive that spindle afference from the muscle spindles. So they can develop a deep boring paresthesia, which the persons describe it as muscle getting pulled from the bones. So deep boring paresthesia due to spindle afference getting involved. So that is posterior column symptom, whereas peripheral nerve level proprioception involvement will produce tingling paresthesia, which is distal symmetrical, and it will not produce the other Lermite and all those things. That is the first positive symptom. Negative symptom, posterior column involvement produce no loss of reflex. whereas posterior proprioceptive fibers in the peripheral nerve produce areflexia. Third, in the posterior column, you have got a ventrodorsal lamination. Whereas in the peripheral nerve, there is no such lamination. That ventrodorsal lamination is vibration, movement, and position. So the medial and the ventral most is vibration. In between is the movement, and most proximal is the position. So patient can have dissociation. The position sense may be totally lost, but vibration may be preserved. You will wonder how it is possible. Vibration is a more finer proprioceptive sensation, which my patient is telling is preserved and unable to recognize a movement. That points to the column. Whereas this kind of dissociation between vibration, movement, and position does not happen in the nerve. So positive symptoms are different, and the reflexes are different, and the selectivity between vibration, movement, and position is seen in column if it is seen, and it is never seen in the nerve. So those are the, so at the end, my patient is knocking out the large fiber also. Any other signs in this? Any autonomic symptoms? Does he have any visceral symptoms, sweating changes, dry skin, dry mouth, or postural hypotension, bladder, bowel, nothing? No?
Patient didn't complain.
So, and she has got a severe weight loss.
Weight loss, yes, ma'am.
So now would you like to summarize the structures involved? Weight loss also we'll discuss later. The structures involved are distal, symmetrical, small fiber involvement. Proximal, predominantly motor, and started with the pseudo-claudication and weight loss. So now what are the things at the end of the history? My first diagnosis for this patient is neuromyopathy. Because I think so. I am not thinking of a radicular neuropathy as the first symptom in this case, even though diabetes can produce radicular neuropathy, that will resemble CIDP. That is due to antibody to the C-peptide. That is seen in young diabetics. In older age group, it is less common, even though it can happen. And second, it is a small fiber that got involved distally. So if it was the proprioceptive fiber that got involved distally to start with, I would have considered a strong possibility of a radicular neuropathy. In this patient, the distal is small fiber, and proximally we got only purely motor. So I am thinking that it is a neuromyopathy involving both the peripheral nerve and the proximal muscles due to a metabolic complications of diabetes. And that can also explain her weight loss, and that can also explain her pseudo-claudication. So poorly controlled diabetes, they are microvascular congestal pseudo-claudication. So my first diagnosis, taking this pattern, will be neuromyopathy of diabetes as the first possibility. And weight loss can happen when there is a poor metabolic control in diabetes. And second, you know that she has suffered from tuberculosis. That is also a wasting disease. So whether it is a combination of tuberculosis plus uncontrolled diabetes that is causing the weight loss and thinking. So my first diagnosis is neuromyopathy of diabetes. Second, of course, we will keep the radicular neuropathies. Radicular neuropathy, we will keep it as a second possibility. And would you like to tell me the classification of diabetic neuropathy, ma'am?
Distal symmetrical sensory
mixed. So distal symmetrical mixed neuropathy, it will not fit into because it is proximal in the lower limb. So the classical distal symmetrical mixed neuropathy, it will not fit into. Second, proximal asymmetrical neuropathy or radiculopathies, that is a diabetic AMA atrophy. That will be painful. So you might have seen so many cases of diabetic AMA atrophy. They are extremely painful. They are asymmetrical, they are proximal, and they do not involve the small fibers. So it is not a diabetic proximal asymmetric plexopathy. So it is not going to the second group. Third group is focal and multifocal neuropathies. Focal and multifocal will be mononeuritis. It can be ulnar neuropathy, it can be femoral neuropathy, or it can be common peroneal neuropathy with or without cranial neuropathy. So focal and multifocal neuropathies will be cranial or purely the peripheral. So it can be pure peripheral neuropathy, mononeuritis multiplex, or it can be cranial plus peripheral neuropathy. That also it is not fitting into. Then you have got uncommon conditions like small fiber, not uncommon, purely small fiber, purely large fiber, purely autonomy. So it is not fitting into that. It is not a purely small fiber, it is not a purely large fiber, it's not a purely autonomy, it's not fitting into that also. Then you have got uncommon syndromes, that is the CIDPs and the neuromyopathy. So I feel I will not call it as a diabetic neuropathy. I will call my first diagnosis considering the pattern which you presented. It started with a small fiber. So it may be a diabetic neuromyopathy is the first possibility. Second possibility is CIDP. Then what is the neuropathies that can happen with what are the other uncommon neuropathies? One I said CIDP, second is the neuromyopathy. Then you have got a glucose toxic neuropathy. You may glucose toxic neuropathy happens in severe hyperosmolar diabetes. They exactly resemble Guillain-Barré syndrome. They will present like Guillain-Barré syndrome, very rapidly progressive. And you see the blood glucose, it is 600, 700. You don't have to do plasmapheresis or you don't have to do IVIG or anything. You just control the diabetes. So it will look like you did a magic. It will very quickly reverse. It is called a glucose toxic neuropathy. So a very rapid rise in the glucose level produces a purely motor radiculoneuropathy which resembles AIDP. And it will recover over 1 or 2 days if you control only diabetes, nothing else is needed. But you'll have to control it very fast, like treating a non-ketotic hyperosmolar diabetic state. It should be managed like a non-ketotic diabetic state. So that is called glucose toxic neuropathy. Then you have got insulin neuritis. This person developed tuberculosis. She was very poorly controlled. Somebody introduced insulin. Then you can develop a neuritis called insulin neuritis. Insulin neuritis is a painful small fiber neuropathy. It starts on initiation of insulin. It is self-limited. It improves over a period of 1 year. So on initiation of insulin, if this patient developed this paresthesia, pricking pain and all those things, then you can consider insulin neuritis. That's these are the other uncommon neuropathies. Then you can consider the hypoglycemia-induced neuropathy, neurological complications. So hypoglycemia-induced neurological complications can be in the central nervous system, where you get dementia. You see, it will bypass the adrenergic and ulcerogenic phase. We tell hypoglycemia has got an ulcerogenic phase. It has got an adrenergic phase. And then you have got the neurogenic phase. So that is why you know when there is an ulcerogenic phase, the gastrin is getting secreted. So you feel hungry and you eat your food. That is why nature is doing that. Because these neural signals are not there, a diabetic will not have the ulcerogenic phase. A neurogenic phase is the adrenergic effect. So adrenaline is released to mobilize glycogen from the stores. So effect of adrenaline will be tremors, sweating, palpitation. So all those things will be the second phase. So ulcerogenic phase, adrenergic phase, and then the neurogenic phase. Initial neurogenic phase is poor attention, poor concentration, unable to attend to more than one stimuli, and slowly sink into drowsiness. And once the sugar falls below 40 milligram, they can develop seizures. So that is neurological, central nervous system. Whereas in the peripheral nervous system, repeated hypoglycemia can present with M&D-like syndrome. How it differs from M&D is, it will be non-progressive if you do not get more episodes of hypoglycemia. So hypoglycemia can present with M&D-like syndrome in the lower motor neuron. But if you prevent the patient from getting more attacks of hypoglycemia, unlike the classical M&D, it will stop progressing. So these are the common neurological complications. So taking all this into account, if you relate this patient's symptom to diabetes, it will come under the uncommon neurological complications, under which, as you are rightly written, it may be a CIDP or it may be a neuromyopathy. So believing that my patient's history is correct, we will consider like that. Second, supposing this person is not a diabetic, other causes of neuropathy like vasculitis, toxic, HIV, so weight loss is there, HIV associated neuromyopathies become the differential diagnosis. So if this person is not having this much diabetes and we think it is unrelated to the diabetes. Third thing you should consider whether the small fiber neuropathy is related to anti-tuberculous treatment. Because anti-tuberculous treatment also produces small fiber neuropathy. So if it is streptomycin, it produces autotoxicity, INS produces small fiber neuropathy, and you know that ethambutol produces retinopathy. So anti-tuberculous drugs can involve the eye, it can involve the ear, and it can involve the small fibers in the peripheral nerve. So how much is contributed? It may be multifactorial also. So how much was contributed by the INH also, we will keep in mind. And one dictum is, I am sure you know that anti-tuberculous drug-induced autotoxicity, neuropathy, and retinopathy are irreversible. You can only prevent them from occurring. Once they occur, they do not reverse. Retinopathy is due to sequestration of zinc from the retina by ethambutol, and it is INH is due to pyridoxine deficiency, and streptomycin is a direct autotoxicity. But none of the ATT-induced neurotoxicity reverses once it is established. So that is of prognostic relevance. Even diabetic neuropathy does not reverse. Can you tell me some reversible diabetic neuropathies? One is the insulin neuritis. Second is the focal and multifocal neuropathies. Third nerve palsy, seventh nerve palsy, ulnar neuropathy, because they are due to vasculitis, microvascular vasonervorum involvement. So mononeuritis is reversible, insulin neuritis is reversible, diabetic plexopathy is reversible, glucose toxic neuropathy is reversible. The classical distal symmetrical mixed neuropathy and the autonomic neuropathies, isolated small fiber, large fiber neuropathies are not reversible. So if it is INH component is also there, it is not going to be reversible. So that is the prognostic relevance. Now you tell me on examination.
On examination, informed consent was obtained. Elderly female, conscious, cooperative, lying supine on the bed, well under time, place, and person. Height was 156 centimeter, weight was 63 kg, BMI was 25.9 kg per meter square. BP was normal with no postural orthostatic changes. Pulse rate was regular, normal volume character with peripheral pulses being well felt, with no radioradial or radiofemoral delays. Respiratory rate is 18 cycles per minute with a thoraco-abdominal. On head-to-toe examination, pallor was present. There is no icterus, cyanosis, clubbing, lymphadenopathy or edema or neurocutaneous markers. No facial asymmetry. Higher mental functions were normal. Coming to the cranial nerve examination, fundus showed NPDR changes.
What all changes you found in the fundus, ma'am?
Ma'am, cotton wool spots were there, ma'am, and few hemorrhages were seen, ma'am.
Cotton wool spots and hemorrhages. Okay.
Cotton blood hemorrhages.
How do you classify diabetic neuropathy, ma'am? Retinopathy, sorry, retinopathy.
Proliferative, non-proliferative, ma'am. If it is non-proliferative, then we will go to the classification.
What will be the changes you find in non-proliferative?
Cotton wool spots. Then hard exudates. Then we can have hemorrhages, cotton blood hemorrhages or flame-shaped hemorrhages.
In proliferative?
In proliferative, we will get neovascularization in the either at the level of the iris or at the level of disc or elsewhere. And we can
what is the importance of differentiating these two?
More strict control will be required once to prevent them from going into proliferative. It indicates poor glycemic control.
Therapeutic differences are also there now. Therapeutic and prognostic. So proliferative is due to counter hormone excess. So treatment options are different. You have got the growth factors and other things. Whereas for the exudative retinopathy, you only use laser. But for neurologists, there is a better classification. We call it as simple diabetic retinopathy. Simple diabetic retinopathy is what you see in most of the well-controlled diabetics also. Over a period of 8 to 10 years, they develop changes in the retina which do not produce this much visual impairment. They are generally asymptomatic, and during routine examination, you find that there is microaneurysm in the venular end of capillaries. So person is a diabetic of 8 to 10 years, you find some microaneurysms in the venular end of capillaries, some fine exudates and nothing else. So that is simple diabetic retinopathy. That is directly related to the duration of diabetic, and you do some laser and it carries a good prognosis. Second is diabetic obstructive retinopathy, which is seen in young diabetics, insulin dependent diabetic. They develop rapidly progressive blindness. And if you look at the fundus, if you are not very careful in describing every aspect of the fundus, you will think it's a normal fundus. So there are some conditions where you say patient sees nothing and you see nothing. One is the cortical blindness. Second is the retrobulbar neuritis. And third is diabetic obstructive retinopathy. Because of the immune complex deposition in the small intraretinal vessels, there is severe retinal ischemia. So if you carefully see, you will not have any stormy changes in the fundus. The vessels will be thin and the retina will be pale. That you may miss, because if you see the exudate or microaneurysm, you are excited. You see the hemorrhage, you are excited, but you will not concentrate on the color of the retina. So the color of the retina becomes pale and the vessels become thin. And then you do the fluorescent angiography. You will find the retinal circulation time is prolonged. And patient needs treatment with the immunosuppressants. Very quickly, you have to use some immunosuppressants because it is due to, before the retina is damaged, it is due to deposition of immune complex. That is diabetic obstructive retinopathy. Next is what you told as the non-proliferative or diabetic exudative retinopathy. This is due to the, I am sure you know much better than me, because diabetes is a polygenic disease. It is not a single gene disorder. Multiple genes are there, and some of them the vascular component is more. The metabolic component is more in some of them, where they will oscillate between hyperglycemia, hypoglycemia, but they don't go into nephropathy or retinopathy. Some of them have the vascular component more. Those people go into this kind of complications. So it is related to the genotype. The vascular complications are more. So if there is a family history of such a phenomena in other family members, such people should be isolated and initiated on insulin first itself. If there are family members who died younger age due to CKD and things like that, there are, skin biopsy can be taken to study the microvascular integrity. Or you have the small vessel Doppler. Not in our country, it's not easily available, but skin biopsy and electron microscopy can be done in some centers, not all places. Microvascular Doppler we don't have. Instead, olden days we used to do this chlorpropamide alcohol flush test. It is called chlorpropamide alcohol flush test. When you give chlorpropamide and red wine, there is a flush reaction normally. So if that flush is not happening in a diabetic, that means the microvasculature is already compromised. So that is olden days test for knowing, predicting whether he will have nephropathy, retinopathy, and how do I prognosticate, should I put him on insulin. So that is the non-proliferative retinopathy, where you find exudates, hemorrhages, cotton wool spots, all those things. Then you have got the diabetic proliferative retinopathy, where you get large hemorrhages, detachment, vitreal hemorrhage, neovascularization, which bleed. That is because of, not due to absolute insulin deficiency or insulin resistance. It is due to counter hormones. So it is the growth hormone and the somatostatins. So it is said that apart from symptomatic treatment of varying degree depending on the severity of the neovascularization, these people are treated with pituitary ablation. Radioactive yttrium implantation in the pituitary is the drug of choice, is the treatment of choice to save vision in such patients. So that is due to counter hormone excess. Then you have got diabetic maculopathy. Diabetic maculopathy is very difficult to treat. You really do not, they become blind and there is no treatment. So that is simple diabetic retinopathy, diabetic obstructive retinopathy, diabetic exudative retinopathy, diabetic proliferative retinopathy, and diabetic maculopathy. So your patient will come under diabetic exudative retinopathy. Next one.
3, 4, 6 cranial nerves are normal. Pupillary reflexes were present with no Ardell-Robertson pupil. Other cranial nerves were normal. No? Coming to motor system examination, there was no obvious wasting that was noted. Tone was
proximal muscles also not wasted.
Wasting couldn't appreciate. No?
Okay.
Coming to the power was reduced in all the muscles. It was 4 in the at the shoulder and.
So it is a non-selective.
Non-selective. Yes.
Non-selective loss of power. The lower limb also non-selective only, no?
Non-selective. No?
Yes.
Apart from that, coming to superficial reflexes, corneal conjunctival was present, abdominal was absent, plantars were flexor. That was like on putting some amount of forceful stimulation. Otherwise, it was mute initially. Deep tendon reflexes were absent. Deep abdominal also was absent. Coordination.
If the deep abdominal and superficial abdominal is absent, what does it indicate? It indicates LMN.
LMN, yes.
If you have the superficial abdominal reflex lost, deep abdominal reflex preserved, it is UM. Both superficial and deep abdominal reflex is lost, it is LM. So the loss of abdominal reflex can be due to local cause. Does she have a flabby abdomen? We don't know. She is a female. Or it indicates a truncal radiculopathy. So she truncal neuropathy, diabetic truncal neuropathy, you know. It will present with parasternal sensory loss. Because the distal most part of the truncal nerves, intercostal nerves, lumbar nerves is the parasternal paraumbilical region. So you will have to look for the gradation from the parasternal to the back. If you look like that, you will get that the least sensation is in the parasternal and the paraumbilical area, and it improves as you go back. So that will be part of a neuropathy, or it can be even a radiculoneuropathy that will abolish both them. So patient slowly, initially the trunk was not at all involved according to you. Later, maybe the trunk is also involved. So the abdominal reflex, both superficial and deep, is abolished.
Coordination was normal. There is no fasciculation or wasting that was seen, and no titubation. Sensory percentage, spinal thalamic tract sensations, like percentages wise, it was like 70.
So you will not call it as spinothalamic. You will call it as a small fiber or pain and temperature. Okay. Because when you say spinothalamic, you are going to the tract. You should say my patient has got pain and temperature, sensory impairment, distal more and proximal is a little more better. And pressure also involved distally more. Air reflexia is there, definitely proprioceptive fibers are involved. Vibration you checked on 6 seconds.
6 seconds.
What is her age?
54, ma'am.
54. So normal person, they will have about 15 seconds distally, and it will lose by 1 second per decade after the age of 40. So for her, it should be around 13 seconds. So it is 50%. Yes, 50% loss of time to vibration. Then?
Cortical sensations like were intact.
So, okay. When there is so much of other sensory loss, you need not look for cortical sensory loss. Okay. So after the examination, would you like to summarize your case?
Yes,
one.
We have a 55-year-old female with background recent ATT intake and long-standing uncontrolled diabetes, presenting with dominant sensory motor weakness. In the upper limb, there is proximal motor weakness followed by distal neuropathy. With
even after examination, the sensory loss is not going beyond the thigh.
no, it's not going.
So it is a muscle only. Proximally, you are having a non-selective, symmetrical proximal muscle weakness, both in the upper limb and the lower limb. And distal, you have got a predominantly small fiber and a mild large fiber. So it is clearly, it is not due to radiculopathy. Proximally, you are not getting any proprioception, and distally, the worst affected is pain and temperature again. So what we thought, so proximal is muscle only. Non-selective, symmetrical, both upper limb and lower limb. Proximal, the most bulky muscles. So it's a metabolic myopathy, and you have got a distal small fiber neuropathy. So I will call my first diagnosis. Most probably it is related to diabetes only. My patient has got a non-proliferative diabetic retinopathy with a diabetic neuromyopathy. What is the importance of saying neuromyopathy? The myopathy component will improve. If it's a metabolic myopathy, it will improve. So metabolic myopathy, you control the diabetic status and control other protein deficiency and other nutritional calcium deficiency, whatever is there, that proximal part is likely to improve. The distal part we do not know. CIDP is very much less likely, because even after examination, it is proximal sensory vibration and all is not affected. And again, it is a small fiber that is worst affected. To call it a CIDP after CIDP is a differential diagnosis, definitely. But after examination, when you find that the pain and temperature is still worst affected than the proprioceptive functions, I will call my final diagnosis will be neuromyopathy only, and that carries relatively, of course, CIDP we will keep and we will evaluate. We can do the femoral nerve conduction latencies and see whether it is suggesting any abnormality. If it is there, maybe some kind of radiculoneuropathy can still be considered. Otherwise, the proximal metabolic myopathy is likely to improve with control of whatever nutritional factors and poor metabolic control, whatever is remaining. You control calcium may be deficient, staying indoor, unable to walk. No, all those parameters, if you correct, the proximal muscle weakness might improve, and the distal neuropathy may get arrested at least with the proper glycemic control. So, what investigations you have done for this patient?
I couldn't get all the investigation. This one, nerve conduction study was, I couldn't get the report, ma'am.
In addition, you, as you are rightly done, you should do the beetle levels. You should do the calcium. You can also do the vasculitic workup, unrelated conditions if you are thinking of. As I told, even if it is a contribution coming from INH, that will not reverse. Diabetic small fiber neuropathy will not reverse. So you have only symptomatic treatment for relief of pain and control the diabetics. But myopathy, as I told, we thought about all the reversible neuropathies of diabetes. Among them, metabolic myopathy of diabetes also reversible. So the proximal part might improve. If a person was taking metformin, also they can develop B12 deficiency. Metformin is one cause for B12 deficiency, or nutritional restriction can produce. If that component is there, whatever is a correctable component, you can correct. So that much improvement will come. And as you know, B12 neuropathy is again a large fiber neuropathy. It is not a small fiber neuropathy. Posterior column, pyramidal tract, and peripheral neuropathy involving the large fibers. But in our patient, there is no evidence for spinal cord involvement. And peripheral nerve is small fiber to start with. Definitely that history is there. So B12 may not be a major contributor. Major contributor must be diabetes and plus minus INH. I think the proximal muscle weakness can improve. You can promote anabolism by giving high calorie diet, strict control of diabetes, correct any calcium abnormality, protein deficiency there means you can give some fresh frozen plasma, then the protein will get corrected fast, and that she may be able to ambulate. That possibility is there. Nerve conduction you can do, but in such situations of severe neuropathy, it is not going to give you any clue. Even if you do biopsy, it will not give clue, because CIDP, diabetes, all these things closely have pathology and electrophysiology. In nerve conduction will be significantly impaired. Snaps will be absent. Motor conduction will be delayed. So you're not going to get any. You will only grade the severity of the neuropathy. You will not get a etiological clue in case of situations like this where are multiple comorbidities and chronic diabetes. But you will have to put your clinical knowledge, and then I think that proximal thing will be multifactorial. It may be nutritional, it may be due to poor metabolic control, and calcium deficiency may be there, and your protein deficiency may be there. Correct all those things, are proximal is likely to improve. Distal part it carries a poor prognosis only, but still she can walk.
Okay.
So my final diagnosis again neuromyopathy with retinopathy of diabetes. You are thinking that you see the non-selective, purely motor, even very late. Only one thing you should look for is the parasternal sensory loss. Parasternal sensory loss will give us another clue whether the short nerves, as the nerve disease ascends, it will involve all the short nerves also. So we didn't get a sensory loss above the knee joint. That is one point saying that the proximal is muscle. But if you had a parasternal sensory loss, it will favor your nerve involvement proximally also, because they are short nerves. But parasternal is spared means again it consolidates our finding that it is a proximal muscle. So these are indirect clues. Nerve conduction or nerve biopsy will be very much less helpful in this case, because most here also you will find few loss of patchy loss of myelin, and you will find some kind of inflammatory cells, and unless you see we call it as a RBC going into the microvasculature. So if you demonstrate that RBC putting a bore into the vessel and getting into the vessel, that is a feature of a vasculitis. CIDP, or you can see all those things, thick myelin onion bulb formation. Otherwise, all these changes are non-specific, and you have to only correlate. In a severely uncontrolled chronic diabetic, any other disease complicating should be diagnosed clinically only. Laboratory will only confirm disease. It will not confirm the cause. Cause cannot be determined because every other conditions will be showing the same kind of changes in electrophysiology and pathology. So I think first possibility is diabetic neuromyopathy. Second possibility, diabetic neuropathy with INH diabetic myopathy with INH neuropathy, and CIDP becomes the last DD. That's all. Any doubt? I am sorry that anyway today I learned. Yes, my son is not there. I knew that there is a button here which I will have to press. That I learned. So next time I will do alone. So sorry I made it. I never made an attempt to learn all these things. Because of that I am poor in technology. So I'm really sorry for that 20 minutes which you lost. Any questions you can ask. Now this also I am telling how to diabetic truncal neuropathy. Yes, diabetic truncal neuropathy is what we have to look for by looking for the parasternal and the paraumbilical sensory loss. Because it can be radiculopathy and neuropathy in the intercostal lumbar region are difficult to differentiate. Because as you know, intercostal neuropathy soon become the part of the radicals. So they are very difficult. Intercostal roots suddenly become the nerve, very short course only. So at the level of the root or nerve is difficult to differentiate. So it can be, but we have to look for, we should look, abdominal deep and superficial is lost. Whether it is due to a local cause, we don't know. Does she have a flabby muscle? Otherwise, it can point here, it can be one pointer for a truncal radiculopathy. Then parasternal sensory loss we should look for. One other question was there, no? What is that question? One more question I think I saw.
What is mass reflex, Devashma?
Mass reflex happens in spinal cord disease, not in element disease. You see, mass reflex is you have got a paraplegia, completely transected spinal cord, but the sacral center is preserved. So you have a lesion in the spinal cord which has preserved the sacral center above the sacral source. Voluntarily, patient cannot initiate micturition or defecation. Voluntarily, patient cannot control anything, but it has got some storage capacity. Bladder and bowel has got some storage capacity because the sacral center is there. So it will store some urine and it will empty automatically. It is an automatic bladder. But automatic bladder, normally in a chronically progressive spinal cord disease which went on to an automatic bladder, it will be periodic emptying without patient having any control. But acute transection of the cord, like conditions, when they go into a automatic bladder, it is not just that periodically it is emptying automatically, but when any stimuli, small touch, small pinprick, or any pain anywhere, that suddenly the patient will go into fluxion and empty the bowel and the bladder. That is called mass reflex. It is due to paraplegia and fluxion. Suddenly you go into short latency flexor reflex afferents in the spinal cord become activated for fluxion posture, and they themselves serve as a stimulus to empty the bladder. Normally automatic bladder empties on its own. Whenever the bladder capacity is about 300 to 350 ml, which is the capacity of the sacral center, automatically the bladder will start emptying. So mass reflex happens when any minor stimuli produces this emptying in an automatic fashion. That is mass reflex. So they will have excessive sweating, they will have palpitation, and they can have very high blood pressure because the autonomic fibers above the lower lumbar region are intact. So they will release a lot of neurotransmitters. So they can develop very high blood pressure, palpitation, sweating, fluxion, and emptying. That is mass reflex. Any other question, ma'am? That's all.
One question I've asked, ma'am, regarding GB syndrome. If GB syndrome is a demyelinating disease, why do we get autonomic involvement, which is a C fiber mediated, when there is no myelin fibers in a C fiber?
You see, you have got now all the classical Guillain-Barrés do not get autonomic involvement. You see, they can have autonomic involvement. You have got the variant forms, which can be small, purely small fiber also. Even though it's a demyelinating disorder, it is described the variant forms. You have got purely cholinergic dysautonomia, adrenergic dysautonomia, and pan-dysautonomia. Pure autonomic type of involvement is described in Guillain-Barré, where even though it's a demyelinating disease, it is found that the stimulating antigen, a similar antigen, some infective antigen is the one which usually precipitates a Guillain-Barré syndrome. So that initiating antigen is the same. It happens in a situation where you have got a Guillain-Barré in clusters. I am sure you know in Karnataka we get Guillain-Barré in clusters during a season, correlating with some special respiratory infection or GI tract infection. In that group, one is developing an atypical presentation. That is treated as a Guillain-Barré variant. Cholinergic dysautonomia I have seen. It will resemble organophosphorus compound poisoning. Because patient will not have other motor weakness. Instead, they will be having diffuse fasciculations, they will have postural hypotension, they will have sweating changes, they can die. They will have cardiac arrhythmia. And you will initially mistake frothing, you will initiate it is, think it is organophosphorus compound poisoning. But the problem is, if you have a loading dose of atropine, you will give in OP compound poisoning. So that much the person will not tolerate, because it is not cholinergic excess. It is only the depletion of the cholinergic stores. So the absolute amount of cholinergic substance in circulation is less. So you give 1 ampule of atropine only, they become dry. They stop fasciculating. They start secreting. That is classical cholinergic dysautonomia. It is only a atypical description. Why the less myelinated fiber gets involved is only by etiological correlation. Same infective antigen is precipitating that. So it is called atypical Guillain-Barré involving the small fiber. So somebody has asked me about bladder, I think, no? Somebody asked about bladder, huh? Neurogenic bladder. Somebody else? So as I have discussed in some previous class, if you have dysuria, hematuria, intermittent stream with normal bladder sensations, normal appreciation of fullness, no other neurological deficit. So somebody comes with dysuria, hematuria, intermittent stream, you have to strain to pass urine, but you are appreciating bladder sensation, you are appreciating bladder fullness, no other neurological cause, you will think of an obstructive uropathy as the first possibility, urological cause. But nothing else is there, it may be neurogenic bladder. Neurogenic bladder, you have many things, as you know, cortical uninhibited bladder, and you have got an automatic bladder, you have got an autonomous bladder, you have got sensory denervated bladder, you have got a motor denervated bladder, and you have got a partial pyramidal bladder. In the spinal cord, 5. One is a partial pyramidal bladder, which may be precipitancy or hesitancy. It will be precipitancy if it is only the facilitatory fibers are getting involved. Inhibitory fibers are getting involved. If the facilitatory fibers are getting involved, it will be hesitancy. And it will be pure sensory denervated bladder if it is a sensory roots and the posterior column. Here what happens, patient does not appreciate bladder cell fullness, patient does not appreciate pain, but yeah, if you tell the bladder, so patient will have a large painless bladder, but patient can initiate micturition if you tell him, because the efferent arc is there. Because he is not getting the sensation, he will just keep quiet. So that is called large bladder, painless bladder. So you have to tell him you have this problem. So once in 3 hours or so, go and initiate your micturition. So the initiating and emptying is possible. If the person tries to empty, he can empty, even though there will be some residual urine and all those things. Patient can initiate micturition. That is sensory denervated. Motor denervated is the opposite, painful retention. Acute Guillain-Barré syndrome, acute polio, the efferent arc is affected. So patient will have severe pain. He is unable to put the muscles into action to empty the bladder. So patient will have to use Creed's maneuver, suprapubic pressure. But luckily, these motor denervated bladders are very brief. Polio, Guillain-Barré, they recover fast. So the bladder is the best bladder, one of the best bladders. So in the spinal cord, precipitancy, hesitancy, sensory denervated bladder, motor denervated bladder. And the next is the automatic bladder. Automatic bladder is what I described. The sacral center is there, higher centers are not there. So once the capacity of the sacral center of about 300 ml is reached, bladder is not able to send this sensation to the cortex to know whether it is convenient or so. Should I hold on to a little more? Up to 1.5 to 2 liters, the bladder can store urine. So bladder is unable to ask the higher centers. When it sends the input higher, it is not going. So it comes back. So from the sacral center, sensations are ascending, they are not able to go up, they come back and excite the bladder. So automatic bladder, the pre-voiding phase, patient may or may not appreciate partial sensation, depending on how complete is the bladder. And the bladder volume is very less. And patient cannot initiate micturition on his own. Micturition gets initiated automatically. That is why it is called automatic bladder. Automatically micturition gets initiated beyond 300 ml. And he empties good amount of urine. About 300 ml of urine will be emptied. And after that, patient has no control over the micturition part. He cannot control the urine in the midstream. And so it will empty whatever it wants to empty. Then it stops. And there is residual urine. So automatic bladder, pre-voiding phase, partial or complete loss of sensation and fullness, cannot initiate micturition voluntarily, periodically empties good amount of urine, about 300 to 350 ml, and at the end of micturition, he cannot even stop micturition in the midstream, and there is residual urine. That is automatic bladder. Then autonomous bladder, even the sacral center is not there. So if you have cardiac venous syndrome, conus medullaris lesion, sacral center is destroyed. So this 300 ml of urine up to that storage will not be also happening. Instead, it is the bladder wall receptors. beta receptors in the body of the bladder and alpha receptors in the sphincters are the only ones which are functioning. As we know, beta adrenergic means relaxation. Alpha adrenergic means contraction. So sympathetic is for storage. So sympathetic receptors in the wall of the bladder are the only ones which are remaining active. Sacral center is not there. So the beta receptors keep on relaxing the bladder. Alpha receptors keep the sphincter closed. So you don't have any pre-voiding appreciation of sensation of pain or fullness. We cannot initiate maturation. Bladder wall receptors have no sensation. So you get a big bladder. Beta keeps on expanding. Alpha keeps on contracting. Alpha is in the sphincter. It keeps the sphincters closed. Beta is in the body. That is the distribution of the adrenergic receptors. Beta receptors are distributed in the body of the bladder and the alpha receptors are in the sphincter. So bladder wall receptors are the only ones that are functioning in autonomous bladder. So the body keeps on expanding, sphincter closes, so you got a large bladder. You have a large bladder, no pre-voiding sensation of fullness or pain, cannot initiate maturation, whereas automatic bladder is not large. It is a small bladder. It periodically empties. And this large bladder accumulates urine beyond its capacity of 1.2 liters. Then the weight of the urine will open the internal sphincter and start dribbling. As you know, 0.3 ml per minute is the rate of urine secretion. So after the critical weight or volume is reached, whatever 0.3 ml gets secreted continuously dribbles. So autonomous bladder pre-voiding phase, no sensory appreciation of fullness, no appreciation of pain, no ability to initiate maturation, large painless bladder and continuous dribbling. That is autonomous. Then you have got a detrusor or external sphincter dyssynergia. That happens in pudendal neuritis, ischiorectal abscess, or following pudendal anesthetic agents or pudendal neuropathy, lymphogranuloma venereum, these focal painful perianal conditions. The external sphincter becomes spasm. That is called detrusor or external sphincter dyssynergia. Their patient will have fullness, patient will have pain, patient cannot initiate emptying. No other neurological deficit. Then you have to check the perineal region, which is a very good bladder. If you miss it, you are doing a crime to the patient, because you can do a pudendal block, very easy to do. The gynecologist will generally do that pudendal block, you do, the bladder empties. That is the test to confirm. Of course, electrophysiological test, nerve conduction of the pudendal nerve and all is not there. Is there, it is all there, but that is not needed. The simple thing, you can give a pudendal block, which anybody can give. If there is no other neurology, pre-voiding phase is all right. Patient has got a full bladder. Patient is wriggling in pain, but unable to empty. No other neurological deficit. You have to look for a pudendal neuritis and give a pudendal block. The external sphincter will open, patient will empty. That is a clue that it is a detrusor external sphincter dyssynergia. Those patients improve either with a sphincter resection or pudendal neurectomy. Pudendal nerve can be section. Very good bladder. So it will improve. So this is in gross quick bladder approach. Pre-voiding phase, voiding phase, post-voiding phase. And you have to keep a bladder diary. Number of times urine is passed and amount of urine passed every time. That should be documented, because large volume frequency may be compulsive water drinking, diabetes mellitus, diabetes insipidus. So frequently passing is not neurogenic. So volume as well as the number and all the phases, pre-voiding, post-voiding, voiding phase, related symptoms of the patient should be documented in the bladder diary. That will help you to type the bladder. Anything else, ma'am? Any other question?
Two more questions, ma'am. If it is polyradiculopathy, is polyradiculopathy usually symmetrical or asymmetrical?
Is radiculoneuropathies? Mainly it is radiculoneuropathies are generally can have symmetry, but there will be some kind of asymmetry, because if you take the proximal part, hip flexion is L1, hip adduction is L2, hip abduction is L5, hip extension is S1. So these roots are distributed. So even though radicular neuropathy, the short roots is the pattern that is getting involved. If you carefully examine, you will find some differences in the power. Whereas non-selectivity and absolute uniform involvement is a feature of metabolic myopathy. One more question. Huh?
One more is on YouTube, they asked, ma'am, why only snaps are affected in MFS?
Snaps are affected in?
MFS, they asked.
Which one, ma'am? Nerve conduction study.
Yes, ma'am.
NCS.
They asked for MFS. I don't know what they're trying to tell by MFS.
You see, snaps are affected if the neuropathy is sensory. Miller-Fisher syndrome.
Oh, yes, ma'am.
So Miller-Fisher syndrome is variant form of Guillain-Barré syndrome, where it is supposed to be brainstem is involved or not is the question. It has not been still established whether the disease is in the brainstem or in the peripheral neuropathy. So ophthalmoplegia, ataxia, areflexia, is it central or peripheral is not yet established. So some people think it is a central one. It's all happening in the brainstem. So the neuropathy component is not very dominant. That is why the motor conductions are not affected. Predominantly, it's a sensory conduction that gets affected because the peripheral component is very less. It is mainly the central component. That is why in Miller-Fisher, the motor conductions are better preserved. Any other question? That's all.
Why do they say there is generalized areflexia in GB syndrome?
You see, in GB syndrome, even after the patient recovers very good power, they remain areflexic for a long time. Why? Because it is the spindle afferent that is the first one to be affected. Even before weakness becomes established, unless it is an axonal variant of Guillain-Barré syndrome, in the earliest thing is to go is the reflex, and the last thing to recover is the reflex. 1A fibers, the spindle afferents, they carry the reflex. They get involved first. Apart from the large motor nerves, it is a spindle afferent. So first one to go and the last one to recover is the spindle afferent. Because the spindle afferent is gone, the reflex is gone early and reflex recovers last. Nerve thickening does not happen in AIDP. In CIDP, it can happen due to repair, due to onion peel, change the myelin, demyelination, remyelination repeatedly happening. CIDPs can have thick nerves. Anything else more? Any other question? No?
No other question.
Thank you.
Thank you.
Once again, I am sorry for my poor technology. Thank you so much for presenting and thank you for discussing very well and thank you for giving me this opportunity.
Thank you so much, ma'am.
Thank you.
Keep your guide.
Coming to the end of this insightful session, I would like to thank Dr. S.R.Chandra ma'am for taking out her time to guide us. We learned a lot of concepts which were simplified in this session by you, ma'am. We always seek your blessings and guidance. Thank you again, ma'am.
I am only telling the pattern recognition, you see. So repeatedly we discuss, we tend to get an intuition into the pattern which evolves. That will help you to design the investigations and then make the diagnosis. So thank you. Thank you for this opportunity. Thank you so much.
Thank you so much, ma'am. A very warm thank you to Dr. Vijay for presenting the case. We learned a lot from your insightful presentation, sir.
That thank you, Vijay, also.
Thank you.
He is always with me, ready to be ready to present when there are no takers and keep this thing alive. So thank you, Vijay. Thank you so much. I had promised you something that I will be. Yes.
A last thank you to all the attentive audiences which kept on asking questions and made the session interactive.
Thanks, everyone. Thanks you. Thank you, all the audience also. Shall we close?
Yes, ma'am.
Yes, ma'am.
Thank you.
We'll end the session.
Yes.